unsullied by us humans, sex is a very good part of human life.
We live our lives in a great deal of hypocrisy, telling our children to do one thing while we do something else.
The quest for control. We all would love it if our lives were a bit more controllable.
Discussions within the Christian community about these questions will be primary for the survival of the Christian community.
Just to highlight some of the ambiguity around the terms old and young, my husband is a college professor, and yesterday one of his students was over, and as he was leaving, he was sharing with us that he didn't have to work anymore this summer. He was just going to go travel around the country, and isn't that great? And Bruce said, boy, I wish I could do something like that, to which the student replied, yeah, well, I'm young. And left. And just as the door closed, I said, so are we. But that's life. Okay. I don't know what to do with the mic, sorry. Yeah, okay. Well, the title of my talk, and I had hoped to have an overhead, but we'll wing it. The title of my talk is Palliative Care, Seeking Healing at the End of Life. The psalmist speaks of dying as a journey through the valley of the shadow of death. The images evoked in this psalm are rich and contain elements of comfort and of danger. In fact, the presence of shadow implies that this valley through which we will all travel contains both darkness and light. These are apt metaphors to keep in mind as we consider the difficult task of dying. I'd like to do several things in this paper. First, I'd like to, although I will focus on the ideals, goals, and practice of palliative care, before we begin, I think we need to first examine some of our individual and cultural attitudes towards dying, death, and suffering. Since relief of suffering is the primary goal of palliative care, I will also provide some definitions of suffering and examples of how suffering manifests itself in the lives of patients and of those who care for them. I'll then attempt to define palliative care and hospice, and Dr. Orr helped me out a lot in that regard, so thank you. This is no easy task because there is considerable disagreement and confusion over the distinction between these terms. And then I'd also like to look at some very specific issues, specifically pain management, and one of the questions from the previous talk centered around pain management, as well as emotional, relational, and spiritual issues, and spiritual distress. I'll conclude with some practical suggestions for patients, families, healthcare, psychological, and pastoral professionals. But before we proceed, I'd like to make a confession. I can't help but I'm an Episcopalian. We're into that sort of thing. But my confession is this: I hate death. By death, I mean not merely the stark fact that our lives will someday end, but also the struggles and the losses that accompany the process of decline and death. Now, this may sound rather strange coming from someone who is a palliative care and hospice physician, and a Christian one at that, but let me explain further. I first began thinking about this after telling one of our oncologists that I had just been to a hospice conference. A hospice conference, he said. Oh, that sounds like fun, hanging around with a bunch of people who like death. From his tone of voice, it was clear that he regarded our activities to be somewhat less abhorrent than, say, cannibalism, but that, in his opinion, they definitely fell on the bizarre end of the human behavioral spectrum. So I did what any red-blooded professional who had just been insulted by an insensitive colleague would do. I got defensive. After he left, we do not like death, I silently fumed. I don't like death. In fact, I hate death. I hate the pain. I hate the grief. I hate the fear, the anxiety, and the loneliness that dying people and their loved ones must often struggle with. In short, what I hate most is the suffering that frequently accompanies the dying process and which, unfortunately, is frequently ignored or forgotten, not only by medical professionals, but also by much of society and sometimes the church. But I also believe that death itself is inherently bad and must be seen as such if we are to avoid an overly simplistic or glib approach to caring for those who are coming to the end of their lives. I believe this is an essential fact for all of us to face as we seek to care for those who are dying and as we contemplate the finitude of our own lives. But, you say, death is natural. It's inevitable. It leads to something better, and good can even come from it. These statements are all true. But they do not mean that death is inherently good or that the dying process is or should be expected to be easy. Let's consider them individually. First, death is natural. This is obviously true. However, there is a tendency in the zeros, noughts, aughts, nils, ohs, or whatever we're calling this decade, to equate natural with good. We have natural vitamins, natural dishwasher soap, natural pesticides with which we kill natural insects, and the list goes on. In the world of marketing, natural is good, and it sells. But natural is not necessarily good. After all, anthrax is natural, and a decade ago when Saddam Hussein was planning on stuffing someone in a missile and sending it our direction, I didn't hear a single person say, "Oh, well, it's natural, it'll be fine." HIV is natural. Pain is natural. While some natural material or processes can be good, they can also be very bad. A second observation is that death is inevitable, and we should accept this as an inescapable fact of human existence. This statement is also true. Death is inevitable, and it is only wise, and I think healthy, to accept the fact that our lives as we now know them will end. However, acceptance of death's reality does not mean that death is inherently good or that it is merely a minor annoyance along the journey to something better. Acceptance should never lead us to remain oblivious to another's suffering, nor should we assume that a cognitive acceptance of death's inevitability should, in and of itself, lessen suffering. And the third common observation, particularly among Christians, is that death leads to something better. After all, didn't St. Paul claim that to live is Christ, but to die is gain, and that he longed to be absent from the body but present with the Lord? As Christians, we do trust that God's love for us endures beyond this life, and that God demonstrated this love most clearly through the life, death, and resurrection of Jesus Christ. So clearly then, death is an evil through which good can be birthed. But when the topic of death and dying comes up, we are sometimes a little too quick to speak of resurrection or to assert that death is merely the gateway to eternal life. We sometimes jump immediately to our future hope without being willing to face the difficult realities of the present. We should remember that even from a Christian perspective, death is inherently bad. Death results in the loss of something valuable and irretrievable. Through the creation narratives and through the incarnation, we understand that God delights not only in human life, but in the earth and all of its inhabitants. It follows then that if God delights in this, so should we. In John's Gospel, Jesus said, "I came that they would have life and that they would have it more abundantly." And I don't think he was talking only about heaven. So all of this points to the fact that life on earth is valuable and that our lives here and now are a gift to be relished and to be offered back to God. Death brings an end to this unique part of our existence, and that ending is a very real loss, a loss that should be mourned. A lack of willingness to face this devalues the present. So why is this so important to remember? Why is it important to take a long and unflinching look straight into the depths of human suffering and perhaps into our own darkest fears? I believe that if we do not, we risk ignoring or minimizing the profound suffering of those around us and among us, those for whom we are called to care. We risk a lack of sensitivity. We risk inaction. So the questions we must then ask are, what type of action should we undertake? And directed towards what ends? These are the questions that palliative care seeks to address. Let's talk a little bit about medical culture. So how then do we respond to death's insistent and inevitable presence in our lives? The answers to this question will spring from our faith, our relationships, values, hopes, dreams, and fears. But my purpose here is to focus on how this question is addressed in the context of healthcare. Much of modern medicine seems to be primarily focused on death prevention, while ignoring the plainly obvious fact that every single patient and every single doctor and every single nurse and every single researcher will eventually die. Death is often viewed as an enemy to be battled with all of our most powerful weapons for as long as possible. There was a New Yorker cartoon that showed a senior physician and a medical student standing at the bedside of a patient who had just died. And the senior doctor looked at the student and looked at the patient and goes, "Shows you how much I know." In our technology-dominated medical culture, death is frequently equated with failure. Unfortunately, the patient's values, wishes, and quality of life can often get completely lost in the struggle to keep them alive for as long as possible. We find ourselves once again in the midst of paradox. We should not treat death and dying as insignificant, yet should we struggle so violently against the inevitable that we fail to see when ameliorating suffering may become our most important task. So, death is bad, loss is real, and dying is difficult. That's the bad news. But there is good news. Where there is suffering, there is also an opportunity for healing. There is much that can be done to help decrease the suffering of dying people and of those who love them. This is where good palliative care can make a powerful difference. So for those of you who are thinking, I came here for a talk on palliative care and I'm getting a sermon, take heart, we're getting there. So what is palliative care and what's the relationship with hospice? The World Health Organization defines palliative care as the active and total care of patients whose disease is not responsive to curative treatment. Control of pain, of other symptoms, and of psychological, social, and spiritual problems is paramount. The goal of palliative care is achievement of the best quality of life for patients and their families. And when I say family, I do mean blood relatives and friends. It's not necessarily fair to assume that blood relatives are the closest people to the patient. They often are, but you need to take that into consideration when you're working with people. Palliative care affirms life and regards dying as a normal process, and neither hastens nor postpones death. It integrates the psychological and the spiritual aspects of care and offers a support system to help patients live as actively as possible until death. It also offers a support system to the family to help them cope during the patient's illness and their own bereavement. So as we can see from this rather lengthy definition, and that was abridged, the focus of palliative care is very broad. All aspects of the patient's life are important, and the needs of the family are also addressed. So what then is hospice? In the US, hospice is palliative care focused specifically on patients who have an estimated lifespan of 6 months or less, and who have declined further treatment aimed primarily at prolonging life. Patients who meet these criteria are eligible for the Medicare hospice benefit, which is quite a good thing, actually. The 6-month rule is not especially clinically relevant. That is, it doesn't have much to do with real life. It's a rather arbitrary cutoff with implications for specialized services and reimbursement. And it's also a little bit problematic because we know that doctors we're pretty bad at prognosis or estimating how long somebody has to live. In the US, hospice care is usually provided in the home, unlike in England or where it started. Although now many nursing homes now work together with hospices in an effort to provide more comprehensive care for their dying residents. As I mentioned earlier, there's considerable confusion about the distinction between palliative care and hospice. In general, palliative care is a broader concept, again, as Dr. Orr showed us. And its goals are applicable in a wide variety of situations. The World Health Organization's above are helpful, but they do focus exclusively on dying patients. And I do actually also work exclusively with dying patients, and we'll be discussing this from that perspective. However, I would argue that any intervention that aims to relieve suffering, whether the patient is dying or is expected to recover, is palliative care. In general, palliation, or relief of symptoms, and maximizing quality of life is an important part of everyday medical practice. It's a very broad concept, but many healthcare practitioners equate palliative care and hospice. Unfortunately, some also believe that hospice means giving up on their patient or family member, and subsequently feel that if the patient's not imminently dying, they do not need palliative care. That would be that rectangle with the vertical line. Nicholas Christakis at the University of Chicago used to call that the over-the-wall approach. It's like, okay, we're done treating, to hospice. So, and that obviously is not what we want. We want continual care throughout patients' lives. So let's look at some of these barriers. Well, some of the attitudinal barriers originate in patients or family members. Many medical professionals have a very poor understanding of the importance of palliative care or comfort-oriented interventions, even while patients are still receiving aggressive or curative treatment. For example, we were consulted to see Mrs. A, a 75-year-old woman with lung cancer who is receiving chemotherapy, but who is experiencing pain, confusion, and severe anxiety. As it turned out, we had been consulted by a physician who was covering for her usual oncologist. And I'm sorry, I don't mean to slam oncologists. I know there are several in the crowd. But when we arrived to see her later in the day, her original doctor had come back and was surprised and not at all pleased to see us. "Who consulted you?" he asked me. "Well, it must have been Dr. X, because it certainly wasn't me. I am treating her aggressively. That's what she wanted. She's getting chemo. Eventually, she'll need you guys, but not yet." He paused, and then he continued, "Oh, all right, you can go ahead and see her if you want, but remember, I'm being aggressive." I remembered. So unfortunately, this perception that chemotherapy or other treatments designed to combat disease and prolong life are aggressive, courageous, and worthwhile, whereas pain and symptom management are viewed as passive, cowardly, or of minimal importance, is widespread. Palliative care and hospice are sometimes viewed inappropriately as giving up. This is simply not true. If I'd had my wits about me during the conversation with Miss A's physician, I should have replied, aggressive chemotherapy must be accompanied by aggressive pain and symptom management and careful psychosocial and spiritual support. Studies have shown that patients who are physically comfortable and whose emotional and spiritual needs are addressed have a better quality of life, are more satisfied with their care, and more likely to be able to cooperate with their therapies. Unfortunately, there's usually a 1 to 24-hour time lapse between my witty and insightful comebacks and the situation in which they would have proved most helpful. But unfortunately, I'm sure similar situations will come up again. Exploring suffering. Palliative care focuses on the relief of suffering. As noted above, suffering is a complex interaction of physical, psychological, social, and spiritual pain and loss that severely and adversely impacts the lives of patients and families. It is sometimes referred to as total pain, meaning that it encompasses all aspects of one's life. One of the most widely cited authors to write about suffering is Eric Cassell. Cassell maintains that suffering occurs when one's integrity or intrinsic unity as a person is threatened and a sense of disintegration and fragmentation takes over. You can see this a little bit if you've ever heard somebody talk about, like, say, if they have a leg that's bothering them, and they'll say, well, you know, I go on this trip, but it's this bum leg, you know, that's keeping me from doing it. And you can hear that separation. There's me, and there's the leg. That's the first kind of break in that unity. So this integrity can be threatened in a variety of ways. For example, serious illness can cause changes in physical appearance, like weight gain, weight loss, or hair loss. Complex abilities like driving or more basic abilities like walking or eating may be lost. Relationships and roles change. It is not uncommon for those who saw themselves as the provider of care to be very distressed by the realization that they are now primarily the recipient of care. Memory and thinking can be impaired. Events or people from the past may be forgotten, and the future that once seemed so promising may suddenly seem alarmingly short. One of our recent patients, Mrs. N, was an 88-year-old woman with advanced cancer whose disease had spread to her bones and lungs. She had been living independently, but due to pain and weakness and shortness of breath, she could no longer care for herself as she once did. She had many friends, but several had died recently, and her husband had died 20 years earlier. As she struggled to come to terms with her own illness and impending death, she said, "I can't believe I'm dying. I mean, I knew I was sick, but I always thought I'd get better. Some of my friends have died, but I guess I never really thought it would happen to me. I don't know what I was thinking." Later, she also said, "I was always the one who helped other people to be positive and hopeful, and now I can't even do that for myself." Her physical pain was quite intense, but her sadness, fear, spiritual unease, and changing relationships also contributed to her suffering. Pain medications helped, but were not enough. All members of the palliative care team, the social worker, volunteers, nurses, chaplains, and physicians worked together to listen, to ask questions, and to provide care and support. Even things that could appear to be relatively insignificant can contribute to suffering. One 72-year-old writer who was dying of lung cancer repeatedly told us, "I am a person who gets up every morning, drinks a cup of coffee, and reads the New York Times. Now, I don't have any taste for coffee, and I don't feel like reading the paper. This is not me." Though she suffered from depression, non-depressed individuals commonly experience a similar sense of loss when daily routines become disrupted. The loss of the familiar can be a source of intense suffering and should never be disregarded. So if suffering results from a loss and sense of fragmentation, then healing, in the sense of restoring at least some measure of wholeness, is needed. It is for this reason that palliative care seeks a broad and integrating approach. So let's talk about some specific issues now. Though palliative care seeks the broad vision of human healing, some issues deserve special attention, and the first of those is pain, and I mean physical pain primarily. I'll also briefly address anxiety and depression, forgiveness and closure in relationships, and spiritual concerns commonly encountered in dying patients. It's only by remaining aware of the importance of all of these elements that we can help patients to begin to recover at least some sense of wholeness. Let's start with pain. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential injury or described in such terms. This means that people commonly describe their pain as gnawing or pressing or stretching or burning or crushing, kind of a feeling of injury. Another definition puts it more simply. Pain is whatever the experiencing person says it is, and it is present whenever they say it is. So note that pain is sensory and emotional. They are intertwined. You can't separate them. And you can see that even when we try to focus on what we think is a purely physical problem, we discover that it too is much more complex than we might have expected. Another important question to ask is, what does this pain mean to this particular individual? It may mean that their disease is getting worse, or that they fear that their disease is getting worse. It may mean that it will be more difficult to get out of bed or out of the house, making them more dependent and possibly socially isolated. It may mean a loss of dignity. Pain may increase anxiety and depression. It can cause sleep disturbances, loss of appetite, and fatigue. Decreased activity and altered posture may place the patient at increased risk for bed sores, muscle pain, blood clots, and lung problems. Relationships become strained. Sometimes pain becomes so severe that people consider suicide. Finally, there is reason to believe that unrelieved pain may actually shorten overall survival. Well, you're probably thinking this is thoroughly depressing, but please know that there is good news. Pain can be treated. The vast majority of persons who have acute pain or cancer-related pain are able to experience significant relief when the proper combinations of medications and other therapies are used. Chronic pain not caused by cancer is more challenging to treat. It almost always requires a combination of medications, psychological support, physical therapy, and other interventions. Sometimes massage can help, or acupuncture or other therapies. But with appropriate interventions, most people are able to experience enough pain relief that their quality of life improves significantly, even if pain isn't eradicated completely. Unfortunately, despite the devastating impact of pain on human lives, and despite our increasing ability to provide significant relief, far too many people continue to suffer from unrelieved pain. In one study of nearly 2,000 oncologists, 86%, that's nearly 90% of them, agreed that cancer pain was undertreated. But only 51% felt that patients in their care had undertreated pain. So yes, that's a terrible problem for other people's patients. Another study found that in a group of patients with advanced cancer, even though 2/3 had some pain medications prescribed, 42% felt that the medication was inadequate, and 36% felt that the pain prevented them from engaging in daily activities. Pain is also very common in elderly people who do not have cancer. It has been estimated that 45 to 80%, it's one of those helpful statistics, of nursing home residents and somewhere between 1/4 of elderly persons living at home experience pain that is inadequately treated. This is a serious problem, particularly as we have already seen pain's devastating effects on human lives. So what are some of the barriers to pain management? Why is this problem so widespread? The answers are as complex as the problem itself. Patients and their families, physicians and nurses, institutions, and even state and federal regulatory agencies may all impede the proper assessment and treatment of pain. Patients are often reluctant to tell their doctors or nurses that they have pain. Some fear that doing so might distract the doctor from fighting the disease, especially in cancer. Some worry that if they talk about their pain, they'll be viewed as a complainer or as a bad patient. Others believe that nothing can be done about pain and therefore they must suffer in silence. Some patients have lost their ability to communicate their pain, such as those with dementia or who've had a severe stroke. The burden then falls on the healthcare professional. Doctors and nurses must ask patients about pain and then listen to them and believe them when they tell us that they have pain. We must take pain seriously and let our patients know that pain management is an important part of their total care. When pain is severe enough to warrant the use of opioids, that is, morphine and related medicines, many more problems arise. Fear of addiction is very common among patients, families, and physicians. However, if a patient has severe pain, they need strong pain medicine. If they have continuous pain, then they need continuous pain treatment. We use similar approaches when treating diabetes, yet we do not accuse diabetics of being insulin addicts. Or I don't anyway. We live in a nation obsessed with avoiding dependence. I commonly hear people proudly proclaim that they have gone off sugar or salt or caffeine or chocolate. As a firm believer in moderation, my first response is to wonder, usually silently, now why would you go and do a thing like that? If I'm feeling especially perverse, I'll mention that I know that I am dependent on caffeine because when I don't get it first thing in the morning, I will certainly develop a splitting headache by 10 or 11 o'clock. More than one person has responded with a slightly scandalized, "So what are you going to do about that?" To which I reply, "Make sure I get coffee." Simple. My headache is a manifestation of physical or physiological dependence. Steroids, morphine, anti-anxiety medications, and some blood pressure medicines all produce a physiological dependence. For practical purposes, this means that they should not be stopped abruptly or a withdrawal reaction will occur. Such medications must be reduced gradually before stopping. Dependence, in this sense, is a physiological phenomenon, not a moral one. Addiction is entirely different. Addiction is defined as, number one, taking a substance you do not need or in quantities that are neither warranted nor safe, so you don't need it. Two, continuing to take or use that substance despite harm to yourself. So not only do you not need it, it's actually hurting you and you're still using it anyway. And number three, engaging in harmful and immoral or illegal behaviors such as lying, stealing, forging prescriptions, etc. in order to maintain the habit. So you don't need it, it's causing you harm, you're behaving in bad ways to sustain the habit. That is addiction. Opioid addiction is very, very uncommon in cancer patients with pain, probably less than 1%. In patients without cancer who have chronic pain, again, this is a much more difficult kind of pain to manage, the rate of addiction is estimated to be around 6%, and studies vary. But this is very similar to the prevalence of drug abuse in the US population in general. In one study of 313 patients with non-cancer back pain who were receiving opioids, that is like morphine-like drugs, 19 of them, or 6%, developed signs and symptoms of addiction, but nearly half of these people had previous histories of drug abuse. This does not mean we should not use these medications. It does mean that we must pay close attention to our patients' histories and their current lives. We should not be afraid to ask how things are going at work and at home, since pain affects and is affected by every aspect of life. Another barrier to pain management is the fear that high doses of opioids might hasten death, and that issue has already been raised today. This fear is particularly prevalent among medical professionals, but has found its way into ethical discourse as well as recent legislation. Now, this is one of my favorite soapboxes, the principle of double effect in pain medication, but if I get up on this soapbox, I may never come down, so I won't go there right now. But I won't go into detail, but scientific evidence and clinical experience clearly demonstrate that these medications are very safe when used properly. In our hospital, the most dangerous medication the medication that causes the most death and other problems is our blood thinners. Not opioids. They're way down the list. We use a lot more dangerous medications on a daily basis, and people don't think twice about it. Unfortunately, until very recently, medical schools and residency programs have not emphasized the importance of learning how to manage pain, and some haven't taught it at all. Misunderstanding, fear, and a lack of experience have combined to produce generations of physicians who not only do a poor job of managing pain, but who are also incapable of advocating for patients by encouraging more enlightened legislation and regulatory oversight. Fortunately, this is beginning to change. The hospice and palliative care movement has helped to raise awareness about inadequate pain management. The American Geriatric Society has produced guidelines on managing pain in the elderly. Just over a year ago, the state of Illinois simplified documentation requirements in an effort to make opioid medications more accessible for patients. And this year, in January, the Joint Commission on Accreditation of Healthcare Organizations, that is the organization that inspects and certifies most hospitals and nursing homes in the United States, required that all accredited institutions assess pain and provide appropriate interventions for pain relief for all patients, no matter what their diagnosis, no matter what they're in the institution for. So change is occurring, and this is very good. What about some other sources of physical and emotional distress? Emotional and psychological distress are also very common in patients nearing the end of their lives. In our recent survey of hospitalized cancer patients, I and my colleagues found that 44% felt distressed by pain, 41% by fatigue, 37% by worry. Nearly a third felt nervous, and a quarter felt depressed. And this was in a patient group who scored very high on measures of spiritual well-being. There was not a relationship between spiritual well-being and distress. They were just as likely to feel distressed in a global sense as other patients. Physical symptoms can increase emotional distress and vice versa. One day during morning hospital rounds, we asked an elderly man with congestive heart failure whether or not he had felt short of breath overnight. His response was sobering. "You always ask me if I'm short of breath, and I never really knew what that meant. But now I know. Last night I felt so short of breath that I was afraid I would die. Then it got worse, and I was afraid that I would not die." Not surprisingly, his fear and anxiety increased as his breathing difficulties increased, and the combination made him long for a more rapid death. Fortunately, medications and breathing treatments decreased his shortness of breath, and his fear and anxiety decreased as well. His suffering had a very profound, if brief, impact on his hopes and goals for the immediate future. Though this patient did not have to make any important decisions while in great distress, it is easy to see how unrelieved suffering might significantly impact decision-making. This, I believe, underscores the importance of aggressive palliative care. Relationships. Tensions and changes in relationships can increase and be increased by physical and emotional distress. Many of our dying patients struggle with feelings of isolation and loneliness. They may feel abandoned as family and friends and even physicians feel uneasy in their presence and visit less frequently or stay away altogether. Some even feel abandoned by God. As I mentioned earlier, role reversals and changes can also contribute to suffering. Many of us in this room are more comfortable when we are giving than when we are receiving. Mothers and fathers, pastors and nurses, doctors, teachers, and others whose lives revolve largely around caring for others may have their sense of identity and worth seriously undermined as they lose their ability to function in these roles. Our social workers and chaplains spend considerable amount of time trying to help patients discover new ways in which they can give to their family and to find value and meaning in their rapidly changing lives. Spiritual distress. In recent years, there has been an upsurge of interest in the relationship between spirituality, religion, and health. Much of the research in this area has attempted to demonstrate that religious beliefs and practices may have beneficial effects on physical and emotional health. While it seems obvious that spiritual well-being is an important part of total health, spiritual dis-ease or distress can definitely increase suffering. I have seen many patients who feel that they have been betrayed by God. What did I do to deserve this? I have been faithful. I trusted God to protect me, and look what happened. Job was not the only one to harbor such thoughts. Theological musings about the meaning and purpose of suffering are rich and often illuminating, but may not prove terribly helpful in the midst of a pastoral crisis. Often people simply need permission to express such thoughts without the threat of judgment or condemnation. They need to know that such feelings are normal and that this represents another area in their life that needs healing. Healing which may or may not occur on this side of death. There's a book called Naked Before God, The Return of a Broken Disciple. It's kind of a story of Jesus and the disciples told from the perspective of Nathanael, the disciple Nathanael, and Jesus continually tells Nathanael throughout the book, Nathanael, heaven is not your reward for being perfect. Heaven is the place where your healing will be complete. Recently, I heard someone talking about a man who had just died of cancer. Our friend said that this gentleman was amazing. He never seemed to be afraid, and his faith remained strong and unwavering. This is a powerful and inspiring testimony, and many people face death with amazing courage and trust. But not everyone is able to do this. Even persons with strong faith may find themselves anxious and confused by the turns their lives take. When faced with uncertainty and change, we are often uneasy. Fear is a normal part of human life. And Christian faith is not a vaccination against fear. It is a commitment to persevering in a relationship with God that is sometimes joyful and comforting, and at other times baffling. At times we have a strong sense of God's presence, and at others there is maddening silence. A recent issue of Christianity Today included a quote by Gardner Taylor that reflects the experience of many dying people, and of most of us, I think. There are days when we can bring before God a deep and glad laughter of joy and gratitude. There will be other days when we can only muster a bitter, angry complaint. If it is honest, be confident that God will accept whatever it is we truly have to lift up before Him, and He will make it serve His purpose and our good. These are truly words of comfort that may bring healing to another's parched and aching soul. So how about some practical suggestions? To patients and families, communicate with your healthcare professionals. Tell them about pain and other symptoms. Tell them about feelings of depression and worry, and don't be afraid to ask for a referral. If your faith is important to you and impacts your medical decision-making, you should let them know that as well. Again, Dr. Orr stressed the importance of having such wishes in the chart. Your physician may not ask you, so it's wise to take the lead on this one if you can. If they're not willing to listen, find somebody else. Ask about palliative care and hospice, and if you want to know, ask about prognosis as well. Just keep in mind that we're not so good at that. We try, but learn to receive with gratitude. It may be more blessed to give than to receive, but it is certainly not blessed to be incapable of receiving. And finally, seek and grant forgiveness. Communicate with those you love. Discuss your hopes and your values with your loved ones. Begin or continue to have the difficult conversations about what you would or would not want in the event that you become unable to make your own decisions. Designate a healthcare power of attorney and review your wishes regularly. Things change over time, so it's not a one-shot deal. It's an ongoing conversation with your families and your physicians. And to the healthcare and psychological and pastoral professionals, I would say ask and listen. If we ask about pain, sadness, worry, relationships, or spiritual concerns, it lets patients know that we think it's important too. I like to think of this as respectful curiosity. They may tell you to back off, but you may also open a door and allow them to express their pain. We also need to ask ourselves, does our need to fix the people in our care render us unable to see or hear what they really need? We need to try and remain aware of whose needs we're really addressing. So dying can be a time of courage, generosity, forgiveness, reflection, and hope. But unrelieved suffering of any kind can be a major impediment. Palliative care makes the relief of suffering a high priority, as much a priority as shrinking tumors or fighting infection. And it strives to maintain a broad vision of human health and healing. I believe that palliative care is about helping people to live as comfortably and as fully as possible for whatever time they had left. Or as a seminary student who had done clinical pastoral education at a hospital for the dying in New York said, it's not about simply staying alive, it's about living. If we return to Psalm 23, we should note what it does not say about the valley of the shadow of death. It does not say that God's presence will cause the sun to come out, the shadows to melt away, and the birds to begin a cheery song. There will still be darkness and shadow, but God will be with us, and even in the darkness, there will also be light. It does not say that things will not be difficult. It says that we will not be alone. In fact, it doesn't even say that we will feel God's presence all the time, but that despite the shadows that may temporarily obscure our vision, God walks with us, now, during and through our dying, and for all eternity. Thank you.
Grab that and get some questions.
Okay, we'll take this
Are there
with
any
me.
questions, if you want to come to the microphone for Dr. Cameron?
Jackie, thank you for your nice presentation. In your syllabus here, it speaks about diabetes, arthritis, heart disease resulting in symptoms of pain and shortness of breath. It seems that much of the discussion about palliative care has to do with pain relief. I want to challenge a little bit, because of my own personal experiences as a cardiologist, that part of the story I don't think is being dealt with. We are being sort of conditioned that hospice care for patients who are at the end of life is the way to go. And I found that some of my patients, very few, I finally had enough courage to send to the hospice, and found that hopefully this organization would visit the patient 5 days a week. They were going to take care of the patient and their problems. Then, as the patient who had a BUN hovering around 100, if it's 90, they're breathing, or 110, they're breathing okay. If it gets down to 80, they're smothering. They couldn't draw the blood but once a month, because their funding would not allow more than that. And so after finding that out, we had to go back to the visiting angels, the visiting nurses who would go and work with us. And so that patient who they had anticipated, because they got in their organization, would die within 3 or 4 months, and they would give them morphine and help them through the suffering, just didn't fit their formula at all. And I guess there are 2 questions. One is, what kinds of things have you done to divide out for hospice care patients with heart disease as opposed to neoplasms? And is there a need for further work to be done to individualize, or is that something that we as physicians are going to have to continue to do?
These are good questions and highlight some of the difficulties surrounding hospice care as a provision of particular resources paid for by the government in particular. Reimbursement is a big, big problem in all of medicine. And hospices vary widely in the services that they provide. Some have very strict limits on what sorts of therapies they will and will not allow, whereas others don't have those restrictions. It is very, as you pointed out, it is some diseases like heart disease, even HIV, their course is much less predictable than, say, cancer. They can get better, they can look like they're on the verge of death, and they can get better. And so those are, the whole issue of prognosis or predicting how long somebody has left is very difficult. This is part of the reason why I believe that the broader view of palliative care, or even calling it supportive care, is the way to go, because our goal is to incorporate this throughout people's lives, through all of medicine. If you remember Dr. Orr's slide on the, the kind of bar with the diagonal, it's like palliative care is part of medical care throughout the entire lifespan. We are nowhere near there yet. People with heart disease should have their pain and shortness of breath treated even if they've got 25 years left. And, it's often neglected. And then the reimbursement issues are very difficult, and they do vary widely between organizations. And I would just encourage you that if you get to the point where you're looking for a hospice, either for yourself or for a family member, that you would ask them very specific questions about the services that they provide. Are they a group that doesn't allow blood draws? Are they a group that doesn't allow antibiotics? I think this has caused a lot of problems because people then begin to view hospice as the people who say no. And I don't believe that that is our job. I believe the job of palliative care, in the broader sense, is to ask why, not to say no. And, but the reality is that is limited by funding. So we, you know, and it varies from institution to institution. That is a big problem, and therefore you should ask very close questions if you are looking for a hospice.
Everybody probably is aware of the wife of German Chancellor Kohl, who committed suicide because she could not stand the pain. I'm a physician, and I hope that I don't come across this dilemma in my patients. And I'd like to get your opinion. If a patient comes to me and he says, "Doctor, I couldn't stand the pain anymore. Just give me something so that I will die." How do you deal with that situation?
Well, usually such patients haven't been able to obtain adequate pain treatment. And if it's cancer pain or acute pain, in a way that's easier to deal with. It's the people that have non-cancer pain, you know, chronic pain problems where this is much more of a problem, where a lot of the therapies don't work quite as well. I would definitely recommend that such a person go to a practice where there is a group, a team approach to managing pain. It's not an individual. Severe non-cancer chronic pain is not a job you should try to do by yourself. I don't. I wouldn't dream of it. It's far too complex and far too difficult. The center we have at Northwestern has physicians, psychologists, psychiatrists, recreational therapists, physical therapists, occupational therapists, counselors, volunteers. You need to get at all the aspects of the pain. You need to get at the, you know, what medications do they need and how can you support them as you try different things? How is this impacting their lives and who can help them with that? How is this affecting their ability to work? So it's a group, you know, no matter what, chronic pain is it's got to be a group of people who try and deal with it. But to people, you know, this is not an uncommon question. And usually what we say is, there's a lot we can do about this. And you know, we're going to try it. It may take us a few tries, it may take a few different medications, but we're going to do everything we can to help you feel better. That, I think, you know, some of the arguments for physician-assisted suicide do center on unrelieved, usually pain. And the reality is usually we can treat pain. And that's why symptom management is so important, because it does have such profound impacts on people's lives. So usually we just have a word of encouragement and say, look, there's a lot we can try, and we're going to stick with you through this. So, I don't think
Thank you,
helps.
Dr. Cameron.